great evening, and thank you all for taking the time to join us for Thursday night. We are going to give it a few minutes and let you all get time to log in until our numbers go up. Again, it is Thursday, February the 27th, and we have some important information that we'd like to share with you all. And is normally people joining by now? So I'm not sure why we don't have anybody that's joined us yet. So we are going to, oh, we got one person, we got one heart. Who's that out there that just joined? The Lone Ranger. We ask that you put your name in the chat, that you like and share and like, so we can formally welcome you in on this Thursday. I'm just going to jump on my phone and make sure that the link is active and that everybody, okay, that's Mary Ann Davis. You're the Lone Ranger. Hi, Mary. Hi, Brother Alvin Slaughter. Hi, Mary Moore. We are so glad that the three of you are here. Hi, Carla. So you did get the link and it was able to get in. Good evening, Sharon, and welcome all of our Greater Grace family. Do me a huge favor. We want you to like and share the stream so that we can get as many as possible on this evening. Hello, Sister Mary. Hello, First Lady Krista Ellis, and welcome to Thursday. We have a wonderful, wonderful session planned for you all. And so we have 10 people, but we need more to join. We've got some good information that we want to share with you. And hey, you see my friends on the side of the screen. I got Dr. Robinson, and she's going to be introducing her colleague momentarily. Praise the Lord, and welcome, Leslie, and welcome, Jean. We want you guys out there to share and like and share. We were on this virtual platform 2 weeks ago, and we are got up to almost 2,000 views. So we're counting on you to share and to like. We don't come just for the sake of taking up time and space. We have planned great sessions for you with a lot of good information. So we want you guys to share and like and share. Praise the Lord, Sister Ronin Robinson. God bless you. So most of you go to Greater Grace Temple, and so we're so glad that you're here today. And I do hear an echo. I'm not sure if somebody has their cell phone on, and I can hear the feedback from that. Hi, Joyce. Welcome to Blueprint for Wellness. So we have 15 people. Now I need you 15 to share the screen and like and put it in your comments so that others will know that we're here so we can go ahead and get started. Praise the Lord, Sister Vanessa, and welcome. We're so glad that you joined us. So without further ado, I know many more of you will join as we get going. So I am going to turn it over to Dr. Robinson, and she's going to introduce her colleague.
Good evening, everybody. We thank you for joining our Blueprint for Wellness series, the second one, and the theme is the mind. And I am so honored to introduce my colleague, Dr. Michael Evitz, and we'll just give you a little bit of an introduction. He's a member of our academic internal medicine staff at Henry Ford Hospital on the Boulevard in Detroit. He assists us in internal medicine, the primary care doctors, and our residents with diagnosing and treating depression, anxiety, insomnia, and chronic pain. He is a collaborator with internal medicine, our internal medicine team on providing care, and he's an excellent excellent psychologist, and he has been a tremendous help in terms of diagnosing anxiety and depression in our patients. He is very compassionate, very thorough, and I present to you this evening Dr. Michael Evetts.
Thank you, Dr. Robinson, and thank you everyone for having me. It's an honor to be here. So happy to do this talk on depression, and hopefully my hope is that everyone will kind of walk away knowing a bit more about depression than they may have previously. And so appreciate working with Dr. Robinson in the hospital at Henry Ford. I've been a health psychologist for about 3 years, or 4 years now, and really enjoy the work because I find I like increasing access to mental health care services for patients, and I find that that's best served in the primary care office. So I've been doing this for quite a bit, and so I'm happy to bestow what experience that I have in terms of understanding depression. Next slide, please. My hope for this talk is to provide you information so that you understand the symptoms of depression and understand what symptoms of depression look like versus things that might seem like depression but might be more typical responses to day-to-day life, like grief or memory concerns, because sometimes that can also look like other things, psychiatric illnesses like dementia. So hoping you can have a better understanding of what depression looks like versus these other difficulties, understanding what the risk factors for depression are so that you can be aware of what are some warning signs to keep out for, and then understanding how is this treated. It is treatable, and so my hope is to help you kind of identify what are some different treatments for depression, and then throughout this slide, through at least twice, I'm going to provide you some resources for accessing services. So that is my hope for today's talk, or tonight's talk. Next slide, please. I want to set some ground rules before we get started in terms of the intent and focus of this lecture. So my intent is to educate folks on what depression is and how it's treated, provide some resources like the resources you should see on the right side of the slide, and hopefully answer general questions folks might have about depression. So I'm very speaking in a broad way to the general community. Beyond the scope of today's lecture is anything in regards to treating depression specifically for anyone in attendance or diagnosing anyone in attendance. That's not something I'm able to do just because I'm not able to see any of you individually right now. You may find that as I start talking about depression or the symptoms, you might think, oh gosh, I think I have some of these symptoms. And unfortunately, I'm not able to answer or clarify whether your symptoms do or do not meet a certain diagnosis. So that is not the scope of this lecture. Certainly, you might experiencing some distress as we talk about this topic because it can be very heavy. So if you need to step away, turn your camera off or take a break, give yourself grace and just step away. This is recorded. If you do happen to experience any thoughts of hurting yourself or worried about any thoughts that you might be a danger to yourself or others, that's probably a sign that you need to get immediate help. So you can either call 911. On the right, you'll also see the National Suicide Hotline number, 988. Those are some crisis numbers to call for more immediate help and assistance. There are different community crisis lines to call to access mental health resources depending on your county. So for instance, folks in the Wayne County area can call Detroit-Wayne Integrated Health Network. Their mobile crisis unit is through the number on the right that you can call. However, if you are experiencing any thoughts that you are worried you might do something that might put yourself in danger, please call 911 to get help to get to the nearest emergency room or ask a friend or family member who can assist you in getting there for more immediate help. So just wanted to lay some ground rules before we get started. Hopefully that will not be the case, but at least you all have these numbers here. If for whatever reason you missed the numbers, we're gonna revisit this slide later on. Next slide, please. So before we get into this talk, and I want to encourage folks to type in the chat or the comments. Dana will help me make sure we try to catch everyone. What have you heard about depression? Whether that's something you've heard on TV, something you've heard others say, Yeah, just what is your understanding of what depression is when you hear that term? And if you don't want to chime in and say something you've actually heard, you can share something that you've heard others say, if that makes some distance to it. So I think some folks might worry, does it's a mental health condition caused by unfortunate events? Yes, yes it is. It can be often triggered by an unfortunate event or a series of events. Often undiagnosed, very true, excellent point. Many folks, I think, experience it without knowing it, and that's also kind of the focus that I hope to address today, but very good. Yeah, a lot of folks might not know they experience it. It can include dark thoughts, which I think for some folks might be an early sign of depression, but they might not be aware. Feeling sad all the time, that is another symptom of depression, and actually is a good characterization of what depression is versus general sadness. Couple comments on grief and loss of family members, absolutely. Those things can trigger depression and sometimes can look like depression. Trauma, absolutely. Trauma is one risk factor for it. Oh, and okay, good. Someone put in, don't want to get out of bed or do anything. That's actually a very good, like, behavioral type of symptom of depression, right? So that's really good to capture because some folks might not feel depressed or think they're depressed, but then behaviorally, they might not do things like get out of bed, or they might be in bed longer than they typically are. In church, sometimes people attribute it to the need for prayer. Absolutely. Faith is an excellent protective factor against depression, or the faith community, whatever that is for folks. It's hard to battle on your own sometimes. Yes, it can be isolating, and sometimes what can make depression worse is when there's isolation or folks not knowing when to ask for help. One comment can be, so some folks might say depression is something that can be prayed away, and for some folks that might work. Other folks might not find that as effective, or they may have tried that and it might not have worked for them in the past. Other folks have made comments in response to depression by saying it's something to just get over, just deal with it. I wish it were that easy. I'm sure if it was that easy, many folks would have done that. But unfortunately, some folks can make minimizing statements about depression. And then it needs medication. Yep, that can be one form of treatment, and I will expand a little bit on that in the next coming slide. So very good comments, everyone. Appreciate your wisdom and sharing what you know. All made very good talking points and touched a little bit on what I'm going to talk about. So thank you all very much for sharing what you know. Next slide, please. So yes, depression is a mental health disorder involving depressed mood or loss of interest in activities for a long period of time. It is not just the blues or sad feelings. Yeah, and it can be a serious condition that some do not take seriously. And I think one of the reasons is some folks might think that, oh, this is just sad, or I'm just sad, everyone feels sad. I'm not depressed, and that might be true. But then what's different from just a sad mood or emotional state is that depression is something that lasts for weeks, sometimes longer than that, and impairs one's ability to function. So someone just commented, can't stop crying, is this grief or depression? You know, and I'm going to touch on that in a little bit too. But yes, think of depressed mood as something that prolongs for weeks at a time, maybe even months, and never really resolves, which is different from just a sad emotional state. And I think the part that I really look for when I'm assessing for depression in patients is, where is it impairing your functioning, right? Are you not getting out of bed? Are you not eating? Are you not doing things that you used to like to do, right? It's when it starts to really impair these areas of your personal functioning that it might be an indication of depression as a need for treatment. To the point of dehydration, yeah, some folks might not be eating or drinking water like they need to. That can be a symptom of it. Next slide, please. In terms of prevalence data, this is from SAMHSA 2022. It was estimated that about 21 million folks of the US adults have had at least one major depressive episode. So what that means is that clinically they met criteria for a major depressive disorder at least once. Within folks 50 years or older, that estimate was about over 5 million adults met criteria for one depressive episode. And then when we get further into those statistics, about 14.5 million reported an episode of severe impairment. And so when we think of severe depression, that means either the depression is so severe that they're not able to attend to their basic needs, or they may be having thoughts of hurting themselves or have done something to hurt themselves. It means very severe life-threatening depression. And then among adults 50 years or older, about 3.4 million folks have met criteria for severe impairment with depression. So those are some pretty high statistics. And my bottom line that I want you to take away from that is that depression is very common. And this is only based on, I think, what is reported or documented. And this doesn't account for the folks who've never sought treatment for depression or never gone to a doctor to get evaluated more. So it's possible that these rates are actually higher. So I wanted to point attention to this slide so that folks understand that if you do experience depression, it doesn't mean there's anything wrong with you or something you're doing wrong or not right. Many folks have depression. Oftentimes it goes undiagnosed or treated, but it's very common. Next slide, please. So what are some factors that contribute to depression? Some folks did a great job chiming in on some factors. Grief is absolutely a factor that can trigger a depressive episode. Anytime we lose a lost loved one, it can certainly trigger feelings of sadness and mourning. It gets complicated even more so when multiple loved ones we care about pass away in succession. Unemployment can be another social event that can trigger a depressive episode, right? If our job is very important to us and to our identity is who we are, and we are terminated for whatever reason, that can evoke feelings of depression or low mood or a lost sense of identity. Of course, there's the financial stress that comes with losing a job, or even if we're still working and we have financial stressors. Those stressors, when they pile up, will absolutely lead to a depressive episode. Lack of support can be another one. As folks lose their social support network, whether that's through isolation or moving away from our support network, that can result in more sad mood or just feeling lonely. As folks get older and their friends and loved ones pass away, that starts to feel isolating and can evoke feelings of sadness and grief, and that in itself can trigger depression. Trauma absolutely can be a trigger for depression as well. And when I say trauma, I'm not only referring to the diagnosis of post-traumatic stress disorder, which has different symptoms that indicate a different mental health diagnosis. Trauma, even when folks don't experience post-traumatic stress, can experience depression, right? Trauma can mean a lot of different things. And when folks experience that trauma, it can affect how one experiences joy or happiness, or can prolong a sad mood state due to the impact the trauma had on them. Or really any significant life event. A big situation, I think, that's happening right now after the election, and many folks are scared for themselves, their loved ones, people in communities they care about. And there's a lot of policies that are in place that have folks, I think, understandably worried about how it will affect one's access to resources and healthcare. That is a significant event that can trigger depression as well. Folks who are planning pregnancy and planning to have children, that can also be a life event that can potentially trigger a depressive episode. That's what we see with peripartum and postpartum depression. And then there are world events, big world mass events that can trigger something. When the COVID-19 pandemic started, a lot of folks, I think, felt depressed, understandably so, because lockdown kept them from being social. I was working in a college counseling center at that time, and a lot of the college students I saw had a lot of depression and anxiety. And I had to explain to them, like, look, you're doing college right now in a mass traumatic event you didn't ask to have. Of course you would feel anxious. Of course you would feel depressed. Many older folks during that period were depressed because they couldn't see their grandchildren or their children, and that was isolating. And so that probably triggered depression for them. So any one of these social factors can trigger depression. On the right side, we look at more medical factors that can also be triggers to depression. Limited mobility as we get older or as we experience chronic health conditions that limit our ability to ambulate or walk or move around. We're not able to be as active as we like. Because of that, we can start to feel sad or down. Substance abuse, whether that's excessive alcohol use or any other type of substance, as folks start to use that excessively, it can sometimes trigger medical illnesses as well, like nausea, shakiness, and folks might get caught where they need to continue to, for alcohol, like drink to reduce those symptoms, and that can, in a sense, make depression happen. And then there are chronic medical conditions like cancer diagnosis. When anytime that happens, that evokes a lot of fear about death and fear of loss, and that can trigger depression. Diabetes, many folks who have a long history of managing diabetes, that could be a potential factor for depression because it's a lot of lifestyle changes and things that need to be managed, and it can be very frustrating, right? Trying to control your A1C and your blood sugars, and then when your doctor tells you that, okay, they're still not controlled, that can be depressing, it can be frustrating, and that in itself can have folks feeling down. Stroke, there's a lot of higher risk for depression after a stroke, particularly with folks who might experience difficulties talking or difficulty moving after a stroke, and because of that, that can trigger depression. Pain is something many folks experience, and when it's chronic pain that never really goes away, that will absolutely have folks feeling down and depressed because, again, it might inhibit their ability to do things they'd like to do. And then on the more medical side of things, there can be certain labs or levels that can affect one's energy that can mimic depression. So for example, low thyroid levels or thyroid levels that are out of balance or vitamin D levels that are out of balance can trigger fatigue, which can mimic depression. My primary care doctor just told me the other day, your vitamin D levels are dangerously low. And I said, well, I'm in Michigan, what else is new? What is the sun that you talk about? But sometimes the idea is to kind of figure out, well, if we help elevate these imbalanced levels, will that help address some of these symptoms? And then I think someone had said that something about not knowing that it could be inherited. Family history, there can be a genetic component for mental health diagnoses. So if there's a family history of depression, it can potentially elevate one's potential risk for experiencing depression or another mental health condition. It does not guarantee that person will, but it just may be one of many factors that could contribute to one being susceptible to depression. So again, very long list here, but you can see that there's a lot of different factors that could potentially have folks experiencing depression. Next slide. What are the symptoms of depression? We've kind of touched on them already. So absolutely sadness, feeling of emptiness or hopelessness. It can sometimes not be so much sadness. It can be irritability or frustration. Like folks will say, doc, I'm noticing I'm being more grumpy with folks, or I'm being short with my family members and I'm not liking that. That can be a sign. Another aspect is losing interest in things like they used to do, which can be like, I used to enjoy knitting and I'm not enjoying that anymore. Or I don't really enjoy spending time with my family like I used to. Those are, I think, more of the emotional or thought related symptoms, but sometimes folks don't experience that or they don't notice that. And so they might think, well, I'm not sad, so I'm not depressed. But then depression can also come with behavioral symptoms too. So changes in weight or appetite. Are you noticing an increased appetite or are you eating less? Yep, absolutely. No motivation. So are you not doing as much as you used to? Are you noticing more fatigue or energy, or just having difficulty getting out of bed? Sleep difficulty is another symptom that we often look for as an early sign of depression. Are you getting poor restful sleep like you're not able to sleep enough, or are you having problems falling asleep? Are you moving or talking slower than normal? It's what's called a psychomotor slowing, which can occur for some folks with depression, where they talk slower or they just talk less. It can result in feelings of worthlessness or guilt, or just having negative thoughts of oneself. On the opposite end of that spectrum, some folks might describe feeling like an emotional numbness, like they don't feel anything. Another behavioral symptom can be isolating from others, right? Like folks will say, I'm not getting out of my house like I used to, or I'm not talking to people like I used to. That can be another behavioral sign of depression. And then there's some other things that might not necessarily seem like depression, but could be related to depression. So concentration difficulty or memory problems can be a symptom of depression. Folks might think, well, gosh, I'm not remembering things like I used to, or I'm forgetting the things that I'm trying to keep track of, and that didn't used to happen. They might think that that's a sign of dementia, but it actually might be a sign of depression, because it can affect one's concentration. Increased alcohol or substance use can actually be another behavioral sign of depression. Oftentimes it's when folks are having difficulty coping with a stressor, and the increased alcohol or substance use is a way of coping, but then that leads to a whole new set of problems, as medically the excessive use can result in other issues. The big and more crucial and critical symptom that we understand with depression is thoughts of suicide or hurting oneself. So that can be general thoughts like, it'd be better if I wasn't around anymore, or I don't want to be around anymore, or the more active of, oh, I'm thinking of a certain way of doing something to hurt myself, or more severe way that indicates a plan. And any one of these thoughts, whether it's general thoughts or more of a specific thought of a way to do it, is a sign to get immediate help and immediate treatment, whether that's going to the emergency room to get evaluated, or asking your support network to help get you connected to treatment for urgent care, because that's a sign of more life-threatening depression. Next slide, please. What are the risks with not treating depression? I think someone made I appreciate someone commenting that some folks might say, well, get over it, right? Essentially, you should be able to handle this on your own, or it's not that serious, which unfortunately it is very serious. When depression's not treated, it can affect a lot of other things. It can lead to worsening medical conditions. So any other chronic medical condition, like I'm seeing folks mention like diabetes, it can make those conditions worse by way of, if folks are feeling depressed and they have low motivation or low energy, they might be less inclined to take their medications like they're supposed to. They may be less inclined to follow up with doctor appointments that they have to attend. This over time results in worsening medical conditions because they're not being treated properly. It can also affect problems at work. Either folks might be more snappy or short with customers or their coworkers, or when depression is more severe, folks might not get out of bed and they might not go into work, and that can jeopardize their careers. It can also affect them at home and cause difficulties at home, whether that's affecting how they interact with their family, or again, not attending to their basic needs, not taking medications, not eating, not sleeping, and that can lead to other medical health problems. I've already touched on before that untreated depression can be a risk for increased substance use. It can also lead to more isolation from others, which almost like feeds into each other. The more we isolate, the worse the depression gets and the worse the condition gets. Depression is an associated risk factor with dementia. And then again, too, depression can be life-threatening, going back to the suicidal thoughts. So it is a serious condition that warrants treatment, and there can be some pretty bad consequences if it's not. Next slide, please. So kind of parsing apart some other things folks have talked about, like grief, for instance. Am I depressed or am I grieving? It's a very good question. And sometimes, oftentimes when patients are in the office and they've lost a loved one, they might get it referred to our team for further assessment. I will say grief is a very normal process. There's what's called uncomplicated grief, which is essentially the typical process we expect with grief, and then there's depression. So with uncomplicated grief, we would expect folks to feel tearful and cry a lot and to experience mood swings. It's a very normal process of grieving a lost loved one. Folks might feel guilty. They might feel guilty for things they regret not doing or not spending time with their lost loved one. That's, again, a very understandable emotion for someone to experience. These emotions may come in waves: sadness, anger. There might be days where you're feeling great, and then another day and you feel awful about a lost loved one. I think there's pressure that folks feel that grief has a timeline and it should be done at a certain point. And unfortunately, grief doesn't have a timeline. It comes in waves, and there's never a timeline for it. Seeking reminders of a deceased loved one, whether that's visiting their memorial or having a memorial service for them or celebrating their life, those are very, I think, normal processes. It can be common for folks to be in shock or denial initially after hearing about it. I sometimes get folks asking too, like, "Oh, I talked to my deceased loved one. Am I crazy?" And I don't use that term because it pathologizes mental health. But I think it's very common for folks to talk to their lost loved ones as a way of coping. The only time I would be concerned is if, they hear a voice that's not their own telling them to hurt themselves or other people. That would be more of a psychiatric concern, but that's different from like typical grief of just, saying, "Hey, I really miss you. I'm thinking about you." Now with depression, what this might look like with grief is, instead of processing those feelings, folks might be making efforts to avoid any feelings of grief. So pushing away or shutting down conversations about talking about the lost loved one, or efforts they make to avoid reminders about the deceased. So they might avoid looking at pictures, or they start to pull away from family and friends because they don't want to talk about it. Not uncommon, we do see elevated or increased substance abuse, whether that's alcohol use or something else, as a way of coping. And again, that's more of a way for folks to avoid feeling the painful emotions of grief. And I think the big difference here in terms of timeline is if we start to notice these mood states of mood swings, tearfulness, that doesn't resolve within 1 or 2 months. And really, the big symptom, again, going back to functioning, is, are these symptoms resulting in impairments where the person's not getting out of bed, they're not eating, they're not doing they're not bathing, they're not, tending to their basic needs? That's more of a sign that this might be depression and not uncomplicated grief. Next slide, please. Another concern that I think folks might have oftentimes, particularly with older adults, is I'm starting to have memory problems. Does that mean I have dementia? A reasonable concern. But one of the things that I try to assess for, and things that primary care doctors like Dr. Robinson assesses for too, is, well, is it dementia or could this be depression? Both. Depression does come with concentration difficulty and can affect folks' memory. The difference, I think, is that with depression, the onset can occur where the symptoms last from weeks to months at an end. With dementia, that onset does occur within months, but may progress for years over time and progressively gets worse over years as the years go by, as their memory gets worse, which is very different from depression. Depression is also characterized by low mood. Versus dementia, mood might fluctuate. You might, I've seen patients with, concerns for memory decline that do not have depression. Their mood fluctuates, but they clearly are having difficulty remembering things that I see is more indicative of loss of memory or dementia. With depression, there's more self-awareness around the memory loss. They're concerned, like, I'm not remembering the tasks that I'm trying to do every day, and that's making me really frustrated. Folks with dementia might not have that same insight around their memory loss. They might not think there's a problem, or I think an early sign of worsening memory is folks with dementia will start to repeat themselves, or they'll ask the same question moments ago that they had already asked. And that's not quite exactly what we see with depression. Depression may result in neglecting one's self-care, or what we call instrumental activities of daily living. So, grocery shopping, paying the bills, managing your medications. Those are these things that are instrumental to managing one's health. And folks with depression might not be able to do those things due to the depression being more severe. However, with folks with dementia, early on, at the early onset of these symptoms, they might be able to do these things, but as dementia progresses, and as I think Dr. Robinson talked about this last time, they're not able to do these instrumental activities of daily living without any assistance. And so they're paying the same bill multiple times, or they're not paying it at all. They're forgetting their medications, or they're driving and getting lost on their way home. That's more what we see with signs of more severe cognitive decline than depression. Now, it might not always be clear cut like that. And so I don't want you to think like, well, if it's this or this, does this mean I have one or the other? You would still want to talk to your doctor about this for further assessment. But generally speaking, what my takeaway that I'd like you to have for this is that memory concerns can be mimicked through depression as well. Next slide, please. What do I do if I think I have symptoms? You can talk to your doctor. Best person to kind of evaluate further. Like, okay, let's ask her some of the other symptoms of depression to see if that's the case. You might not feel depressed, so it never hurts to discontinue attending your annual medical appointments and attend your annual physical. As medicine is advancing, a lot of primary care doctors know to at least screen for depression once a year. So you might do a questionnaire that asks, are you feeling down, depressed, or hopeless? And if not, great. See you in another year, or in 6 months. Or if you do screen positive for depression, your doctor's there to ask you some more follow-up questions. You can also reach out to your support network. Ask friends or family, hey, I'm not sure if something's going on. Have you noticed any changes recently? They might notice and say, yeah, I've noticed you're not as talkative as you used to, or you seem really quiet lately. Is everything okay? Sometimes just having that back and forth feedback can be helpful. If you do think you're depressed and you're worried about, do I need to worry about my safety? Some things you can do to preemptively keep yourself safe is remove access to any lethal means that could be used to potentially harm yourself. So removing firearms or weapons from the home. If you take medications, obviously we don't want you to not take your medications, but if we don't want folks to be at risk of taking medication to the point of causing harm to themselves. So in that sense, I usually recommend that ask a trusted family member or friend to dispense the medications to you. So these are a way of means restriction, is just keeping your environment safe so it minimizes the risk of doing something to hurt yourself. If you are more concerned about more imminent crisis, like if you're thinking, gosh, I'm really starting to have some bad thoughts and I'm really worried I might do something, that might be sign for going to the emergency room or calling one of the crisis hotlines for more immediate guidance, but it's not something to just wait and sit on. Ultimately, it's about asking for help. So whether that's 911, 988, the National Suicide Hotline number, or asking your trusted friends or family, the point is just ask for help at that point. Next slide, please. How do you treat depression? Medication can be one. Usually with medication, I am not a medical doctor, so I don't prescribe medicine, but I do make recommendations to physicians like Dr. Robinson, where I say, you know what, you're telling me you're not eating, you're not sleeping, you're not getting out of bed. It sounds like your depression's really affecting your functioning. I think a medication might be helpful, at the very least, to lessen the intensity, and maybe it might improve your sleep. It might improve your appetite. It might improve your mood just a little bit so that you can start to function again. That's usually when I suggest medication might be helpful. It does take some time to take effect, so it does take about 4 to 8 weeks of taking once per day as prescribed. So it takes some time, which is why medication is not the only treatment, right? There's also psychotherapy. which psychotherapy and medication as a combination together have very good success rate for improving depression. Therapy is not just talking, it can be, but you are meeting with a professional who has training in therapy. And so different therapies have different approaches. Some help you understand what thoughts are associated with worsening depression and how to manage those thoughts. Other therapies go over more behavior strategies of like, how do we cope with depression, or how can we cope when our negative thoughts start to come up? Or just coming up with other problem-solving strategies to see, well, maybe if we try this, it might start to improve your mood. The big piece, though, that makes therapy different from, say, talking to your friends and family is talking with a therapist is confidential. It's private. What you say with them stays with them. There is some limitations, obviously. What I tell patients is if I have concerns you're at risk of hurting yourself or someone else, I might need to break confidentiality to get you connected to more immediate help. But overall, with a therapist, they stick to whatever, they hold private whatever you share with them. Next slide, please. But wait, Dr. Evans, I have questions, which is very common with medication. And common questions I hear with medication is, what are the side effects? They vary. It depends on the medication. Some examples can be nausea, some drowsiness. Usually side effects are expected to resolve after a day or two, but are mild, and they're usually meant, while there are side effects, the benefits are typically expected to outweigh the risk of the side effects. Other folks have asked me, well, will it change my personality? Not really. The way medications work is it's meant to change hormones or neurotransmitters in your brain by increasing the production of them, and the idea is that by doing that, that can help improve folks' mood, but it is not about changing one's personality or who they are. Some patients have asked, well, will I become addicted to it? There's no certainty, but generally speaking, antidepressants have a low risk for dependence. Most primary care doctors are comfortable prescribing that or don't have as much concern with that. And another question is, will I have to take medications forever? Not exactly. It might. I think some patients find that after taking the medication for a couple months, and if the symptoms improve, they can talk with their doctor about weaning off of it and discontinuing it. And for some patients, their depression never returns. Other patients, they find that, okay, once I got off my medication, I started to feel depressed again. Maybe it'd be better if I went back on it because I like how I function when my depression's not as bad. Regardless, the bottom line is you want to talk to your doctor and ask these questions, because your doctor is going to be the best person to guide you about what to do if you have side effects, what to do if you are concerned at all about dependence or anything. They can answer these questions for you. And if you have other medications, they will be the best ones to identify what's the best medication to start you on that won't contraindicate with the other medications. Next slide, please. So there's a lot of different types of therapy. I won't go into all of them, but one of them that I did want to focus on is one that has a lot of evidence that supports benefits for treating depression, anxiety, substance use or alcohol use or stress, or even just lifestyle change that folks would like to make, and that's cognitive behavior therapy. Cognitive behavior therapy is a solution-focused type of therapy that targets how do our thoughts, our feelings, and our behaviors all relate to understanding depression, anxiety, or other mental health symptoms. A lot of the interventions that I do with CBT involve helping folks recognize, well, what thoughts make your mood worse? I sometimes will problem solve with them about different strategies of how they can cope with depression or stressors. I might help them develop ways of trying to establish new routines and build their confidence towards making new lifestyle changes. And then others might be more ways of mindfulness-based approaches of just practicing strategies to help them calm or relax. Ultimately, though, I'm working with the patient on this. I don't tell them what to do unless I know that that's something they're interested in trying to change. So I do use a shared decision-making approach with the patient, kind of start with, well, which do you want to approach first? Next slide, please. So this graph is one example of how cognitive behavior therapy operates. So if you point your attention to the thoughts part on the green section, automatic thoughts, which happen so quickly we might not be aware that we're having them, can be things like, oh, I'm no good, no one likes me, I fail at everything. I'm never going to get better. You notice these are all negative statements. Any one of these statements, as they start to filter through our minds throughout the day, can shift to negative mood states, to depression, irritability, or sadness. And as these thoughts cycle and these mood states continue, behaviorally, we might start to notice having difficulty sleeping, changes in our appetite, we might start to feel low energy, and then we start to withdraw from others, or we might not do things that we like to do, and we're not participating in activities. So that's how cognitive behavior therapy used depression as this cycle of negative thoughts, feeling negative mood, and resulting in behaviors where we're doing less. Next slide, please. So one of the interventions that CBT does is called behavioral activation. So as we understand depression, where if we're not being active, doing what we like to do, our depression gets worse because we start to feel bad about this. So behavioral activation is where I would talk with the patient and say, what's something did you like doing that you want to do again? And I usually try to pick something slow and small and say, why don't we try it once a week for 20 minutes? And by doing that slowly over time, the hope is that by doing something that matters to the person, they start to feel better about themselves and it becomes reinforcing. And that in itself is one way that CBT can treat depression. Next slide, please. So, big takeaways here is that depression is very common in older adults especially, and it can be treated. Signs of symptoms in depression may vary, so if you don't feel depressed, you might wonder, well, am I noticing other behavior changes that might be a sign of depression? Reaching out to friends and family can be helpful. You know, asking for help is very key in one way of addressing depression. And then preventative strategies are living a healthy lifestyle. Next slide, please. So for example, remain physically active, you know, even if it's just going for a walk around your home once a day, just doing something active can help prevent depression. Focusing on routines to ensure you're getting good restful sleep, take your medications as prescribed, eat, drink water regularly, remain engaged in your community or your family, continue doing the things you like to do. All of these things can help prevent depression. Attend your doctor appointments regularly. Your doctor is looking out for you too and can also observe, oh gosh, you normally manage your diabetes and this time you haven't taken them. Is everything okay? And then plan ahead. You know, think about what are some warning signs of depression. Oh my gosh, my loved one is getting really sick. It's not looking good. I need to be monitoring how I'm feeling throughout this grieving process. Again, removing access to dangerous objects from the home if you're worried about hurting yourself, or if you feel a recurring depressive episode and just want to think, I'm feeling depressed, let's make sure that I can keep myself safe, and ask for help. You know, reach out and ask for friends or family, like, hey, can you check on me, or is it okay if I reach out to you if I'm having a really bad day? All of these steps are good proactive ways of helping you treat depression. Next slide, please. If you're trying to seek mental health resources, you can contact any of these numbers based on the county you're living in. Most of these are community mental health access resources to get you a phone screening and then establish with a mental health provider. Most of this is for Medicare and Medicaid, but I think we can advise you on getting connected to mental health resources if you have more of a commercial insurance. Certainly you can talk to your doctors as well about what are some treatment options for depression. I didn't put it on this slide, but if you go to psychologytoday.com, that is a online listserv where you plug in your zip code and you can find therapists who are in the area, and you can search by insurance. And then of course, there's the National Suicide Hotline for more immediate crisis. And with that, I think that is it. So next slide should be opened up for questions. Thank you all for your attention today.
Wow, what a powerful presentation. Let's see what we have in the comments. Let's see, what do we have here? Sister Susie Shepherd Mosley, this is very, very good information. Thank you so much. Yeah, I'm over here like, wow, I am so grateful that you were able to be with us on this evening.
Absolutely.
You got some more. Excellent. Very informative, good information. So I want you to know, Dr. Evans, am I pronouncing it right?
Yep.
Okay. So we stream to 4 different platforms. So I will keep you abreast. If someone wants the presentation, you can send it to us and we can make sure that they get it. The last time we were on this platform, it was 2 weeks ago, and we're up to, like I said, 1,900 and something. And so I am sure that the numbers will increase because those that couldn't join today, they will definitely be able to go back and view it for at least 30 days. Now they're starting to remove videos from Facebook after 30 days. So we will see where we go with this. But again, I want to thank Dr. Robinson for affording us the opportunity to connect with her colleagues. It's been a wonderful, wonderful evening, and all of the comments are coming up. Everybody's saying excellent and how they enjoyed it. We will be back on this platform in March to bring another one of Dr. Robinson's colleagues, and we will be in tune with you to get you that topic out very soon. On Dr. Robinson, do you have anything you want to say before I conclude us?
No, I just again want to thank Dr. Evetts for that wonderful, wonderful presentation. And I think a lot of times, especially, if you are, a Christian or faith-based, you hide your feelings. We're supposed to be strong. We have a face sometimes with when we go to church or when our families and friends are around, but then when we're by ourselves, we're despondent, we're crying. It's just sometimes it's just a facade. And I like what Dr. Evetts said, you have to face your feelings. You just have, and I think all of us at some time get depressed, with all the things that are going on. We lose loved ones, we get a bad diagnosis, and then certainly we can always, pray and go to the Word of God. But I'm a firm believer that there are times that God wants us to take advantage of those that He has blessed with medical knowledge and for treatment. So it's not a sin. Used to be a stigma to say you were depressed, in the church. It was a demon. You're not, you got a demon. You're not depressed. So I think this was just excellent. And I tell patients all the time, depression is an illness, just like diabetes, just like high blood pressure, just like heart failure. So that's, just thank you again, Dr. Evetts. I really enjoyed it.
Absolutely. Thank you all for having me. And absolutely, you're right, Dr. Robinson. It is okay to feel feelings. I often tell patients your feelings are valid, and sometimes it's about just giving you space to feel them so that they're less overwhelming. And I think the big takeaway too with depression is it's okay to ask for help. It might not be your doctor, but just please ask for help. That's, I think, another important lesson. And no need to hide it, although it is valid that depression has been stigmatized, unfortunately.
Well, thank you both again on this evening. I'm going to take you guys off screen. And we want to thank our Bishop Charles H. Ellis III, for affording us this platform. And I'm going to put the banner up just in case. We have some out there that would love to sow into our ministry. It's scrolling at the bottom, how you can give. And not only that, on this coming Saturday, all of you that are out there that attend Greater Grace Temple, and if you are a powerful woman of purpose, we're going to have prayer in the sanctuary. Back at the church, we will be located, though, this time in the choir room. That is this Saturday, March the 1st at 10 a.m. And we certainly want to see you there. Now that we know about depression and some things that contribute to those factors, we're going to get together and we are going to cry out to our Lord and Savior, Jesus Christ, because We haven't done this since pre-pandemic, right? We used to come together at least every Saturday for prayer. So we're certainly looking forward to seeing you there under the sound of my voice. Please come, bring a friend, a loved one. And then if you're not able to, take that time from 10 a.m. to 11 a.m. to worship with us in your various locations. Then on Sunday, we are going to have a session for all of the powerful women of purpose. We want you to come with your ideas and your thoughts, how you would like to see this year go, and some of the speakers and some of the things you'd like us to plan for you. So that's going to be immediately following morning service, and we ask that you come prepared. There will be light refreshments, and that will be immediately following morning service, and that will be in the banquet hall. So we want to say God bless you. Thank you for showing up. And if the Lord says the same, we'll be back in March for more sessions on the mind. God bless.